What's up, everybody? I got 6 o'clock on my end. So we're gonna finish up the chapter 29 that Rob finished up for y'all, and then once we're gonna roll these last few slides, and we'll roll right over into our chapter that will be for tonight. So you will have 2 tests opening tonight, but you got some time to take it, so you're pretty good. All right, so when you are talking about general principles, is designed to protect and maintain the critical function of the CNS. So what we need to do is establish an adequate airway, control breathing, and provide adequate circulation to maintain cerebral perfusion and assess the patient's baseline level of consciousness and continuously monitor it. Our biggest thing is what right there is we want to make sure that we establish the airway, that is taken care of, and we don't have to put a NPO or just an aftermarket airway to secure that airway. That's our big thing that we want to make sure is secured and that is taken care of prior to any of major anything else that's going on. We need to make sure we address those. The airway is the most important. All right, so managing the airway, what can we do? We can perform a jaw thrust. Once the airway is open, maintain and cervical spine in a neutral inline position until you have placed the cervical collar. Remember, I talked a while back, I like using C collars to kind of hold my tubes. Those are once we place a tube in, I like to put an ET tube down, and I like to use a C collar that will hold the neck in place, and it's the same thing. It helps. So once you get those aftermarket airways in, think about using a C collar to help you out there. So right there, we're showing how they're just using the holding the C spine in place while another provider puts on the C collar. So we talked about this before. The only time we remove anything out of the airway, if it's out of its face, neck, or anything, if it's affecting the airway, we talked about if it's in the feeding the cheek. Once you clear the airway, check for ventilations. Maybe that helped. Maybe it fixed the problem. We're always going to give supplemental oxygen to any patient to suspected a head injury, particularly anyone who is having trouble breathing. Use a back valve mask with high flow O2. Considering calling ALS, it's going to be beneficial to have a paramedic there to help you either do that advanced airway, some IV skills, some drugs, some stuff like that we can use. So think about calling for assistance and bringing backup. Start talking about circulation. What are we going to do? This is the beginning phase of CPR. If the patient is in cardiac arrest, we are going to have bleeding inside the skull may cause an ICP to rise. That is an intracranial pressure to rise to life-threatening levels. You can almost always control bleeding from a scalp laceration by applying direct pressure over the wound. And remember, facial wounds, facial lacerations, facial bleeding is going to be serious. It's going to bleed pretty heavy. So remember that. If you suspect a skull fracture, do not apply excessive pressure to the open wound because you may be applying that broken piece of skull, pushing it in towards the skull of the brain itself. So remember that. Usually the result of hypovolemia caused by bleeding from other injuries. We talk about shock. We always want to transport, well, where is my cursor? Transport immediately to the trauma center. That is the biggest thing we can do for that patient at that time, is transport them rapidly. So Cushing's Triad. So this is something that you probably want to pay attention on. There's probably a test question here or there, or even on registry about. So Cushing's Triad is increased blood pressure, which is hypertension. It is a decreased heart rate, which is called bradycardia, and an irregular respiration similar to Cheyne-Stokes or Biot. Those are the 2 different types of respirations you can have. Cheyne-Stokes and Biot are the ones that we're going to consider when we talk about respirations. So those 3 things are what considers Cushing's Triad. If this process is allowed to continue, if you are unable to fix one of those 3, it is going to be fatal. You need to manage the shock, provide high flow O2, ventilate if necessary, and avoid hyperventilation. We don't want to hyperventilate a patient at all that is going through Cushing's Triad. Sorry, there's a local Air Force plane that's landing out here at our local airport, and it's like, God, it's got to be right over our house. It's super loud. That's what cooked me for a second. All right, so following standard precautions, what are we going to do? Remember to wear we're going to maintain the patient's airway while keeping the spinal in position. Always provide supplemental oxygen. We're going to assess respirations. We're going to make sure that those are always followed at every single patient. Perform a jaw thrust maneuver. We know that if we suspect any type of neck injury, because that's what we want, we don't want to create a neck injury. Consider it an OPA, having suction available, and provide supplemental oxygen. So this is what we're going to do as a jaw thrust. This is the EEC method. If y'all have remember CPR and all that, I know I like the KISS method. Is keep it simple, stupid. So this is going to be our E right here, E and the C. Keep the EC method there. And that's when we're going to push for the jaw. That dates back to your basic CPR method. All right, so on spinal motion restriction for the cervical spine, we are going to immobilize the head and trunk so that the bone fragments do not cause any further damage. Even small movements can cause significant injuries. In your books on 29-1, there's going to be a diagram on how to do all that, but we are never going to force the head into position. If this is something that the patient is unable to do and they are not able to move their head into a certain position, don't force it. Leave it like it is. Just make sure you pat it so it doesn't cause any other issues. You may have muscle spasms in the neck. This created a very bad neck sprain, and they can't move. They may have substantial increased pain anytime you try to move it. They may have numbness, tingling, or weakness in the arms or legs. And it's compressed airways or ventilation, compromised airways or ventilations. In these situations, stabilize the patient in a head in whatever position that it is currently in that is not causing them pain at the time. The cervical collars do provide preliminary partial support. They are that's kind of like, I call them a headrest, is basically all they are. And they should be applied to every patient who has a possible, and here's the key word, a possible spinal injury based on the MOI. If the patients are up, well, first off, you need to rely on what your local protocols are. If your agency says every single patient in car wreck is transported gets a C-collar, okay, then do it. National standard says if a patient is denying any type of neck or back pain and they're up walking around, most time you can leave those off the backboard and there's you can transport them as is. Now, during transportation, if they turn around and say, hey man, my neck's starting to hurt, put them on a seat collar. That's the easiest thing to do at that point. Now again, on your books, 29-2, that is a skill drill based about how to do seat collars. Once the patient's head and neck have been manually stabilized, assess for a pulse, assess motor functions, and sensations to all extremities. Then assess the cervical spine area in the neck. Maintain manual support until the patient has been fully secured to a backboard. Now, the reason why we say that, anytime we apply that C-collar, we want to do a PMS to all four extremities. And the reason why is to make sure that there has been nothing prior and post application of the C-collar. So you should have all that information prior, and then now we're going to turn around and do it again post application. We're going to secure the patient to the backboard. Another procedure to move the patient from the ground to the backboard is a 4-person log roll. Hopefully we've discussed that in, hang on one second, y'all. Sorry about that. It started storming at my house. My dogs were outside. All right. So hopefully y'all have done this in a boot camp. If not, I know that it will be coming up. So trying to talk to y'all virtually how to do this is just not going to happen. They're going to have to teach that at a boot camp. In which the 4-person log roll is very easy. You're just trying to make sure that this person is not going to be turning at all. We are going to be controlling all the motions for them. All right, so you may also slide the patient onto a backboard. You may turn around and just, it's an up and down movement. It's not you don't jerk them at all. It's a very slow process. It's a very maneuverable thing that makes the patient comfortable during transport, moving them from the ground to a backboard. Um, we're gonna skip that one. I'm on vacuum mattresses. That's really not something that we do. So anytime you have a patient that is sitting, we're going to be using the KED. If you don't know what a KED is, we have one here in just a minute. I'll show you the picture of it. These are short backboards or short spinal extrication devices. They do help restrict any type of movement when they're sitting. There are certain things you can do to when you add them. Some of the things that you should not, as what does it say? Expectations include situations in which you or your patient is in danger. You need immediate access to the patient. The patient injury justify urgent removal. So anytime, so it's life over limb. If you need to remove that patient, otherwise, if you don't move them right now, they're going to die. And you move them, and that they do have some type of injury post you moving them, that is understood because it's life over limb. Now, again, documentation is your key when you start to do this. So you need to make sure that you document why you move that patient super fast without any type of precautions. So a patient who is already standing or walk around should be able to sit down gently and transfer it into a position in which the spinal motion restriction can be maintained. You can also board them as they're standing if that's something that takes place. And then you can turn around and lower them to like the stretcher or to the ground. Those all can be done and also at the same time. If the MOI and clinical indications suggest a spinal injury of the patient and inability to protect his or her spine, establish spinal motion restriction. We are going to anybody that says they have spinal tenderness or pain, an altered level of consciousness, neurologic defects, an obvious anatomic deformity of the spine, or high energy trauma in an intoxicated patient, or one with a distracting injury. And two, if you're just like, man, I don't know how they are up walking around after that accident. But the MOI suggested, so let's just put them in a C collar just in case. So during our assessment, the pain in the spine may be missed because of shock. Their epinephrine, their fight or flight may be going off, and they have just not feeling it yet. Because of any manipulations of the unstable cervical spine may cause permanent damage to the spinal cord, you have to assume the presence of spinal cord injuries in all patients who have sustaining type of head injuries. And you want to use and make sure you use inline stabilization of a cervical collar and long backboard in any of those situations. Here is a picture of a KED. The KED stands for the Kendrick's device. 4X, so there it is. It's KODE, as you can see down here. But I'm so used to calling them KD. It's a Kendrick's device for extrication. These are phenomenal. They're great in adults, moving them from the seated position, and they're also wonderful for pediatric issues. You can use this as basically like a taco, wrap them up, and you can turn around and secure them and keep them that way and transport them to the hospital. I've done that multiple times for pediatrics. As you can see, this is the very back side, red to red, yellow to yellow, green to green, and then white to white. The whites here is for the groin straps. These are handles to help pick the patient up. So these don't go anywhere. This is for the head. This is on the very back side. Your head, same spot on the opposite side right there. And this is for another handle right here. So all these are made as a extrication tool. I know some agencies across the US mandatory use of this anytime that they move a patient from the seated position to a backboard. They use KEDs on the regular. A friend of mine works for an agency that on their fire truck, they have 10 of these. They use them so much. Here's your long backboards. This is more of the scoop stretcher here. You can use this in a water situation, or I've also used these in pelvic injuries. They're phenomenal for. This is just a different type of a backboard. We have one similar to this offshore. You can always say the wider end is for the head and the narrow end is for the feet. We have one of these that are just kind of the same size up and down offshore. Sometimes the straps are wind through like this. Ours clip on these little bitty hooks. It just varies on different type of manufacturers and color too. Any type of helmet removal, the only time that you want to remove an helmet if there is no impeding airway or breathing problems. We want to make sure of that. So if this does not interfere at all, we want to leave it in place. You can properly mobilize the spine with the head on. You need to make sure that you can see them. I know sometimes have the full face, some have, I'm not a bike rider, so I can't tell you the different type of helmets, but some of this, if you can't access the airway at all and you're concerned, you need to make sure that you document very well why you move the helmet and take the helmet with you. But if you don't have any issues at all, you can leave it in place and transport them to the facility that way. Hang on one second, y'all. All right. So if the helmet is removed, or remove the helmet if it is a full face, it's making assessments or managing airway problems or reduce face guards. If it prevents you from properly mobilizing the spine, it allows excessive head movements and the patient is in cardiac arrest, you have to have access to their head. That's one of the things that you need to make sure that you can control is the airway during a cardiac arrest. So helmet removal, removing a helmet should always be at least a two-person job. Your technique for helmet removal depends on the actual type of the helmet worn by the patient. You and your partner should not move at the same time. It should be a one-for-one deal. You should first consult med control before you make any of those decisions to remove a helmet. The advantage of this method should allow the helmet to be removed with applications of less force, thereby reducing the likelihood of motion occurring to the neck. We want to try our best to stabilize it the best that we can. The disadvantage is there are some times that you can to movements. Remove the chin strap, which is obvious because that's really the only thing that holds them on. Remove the face mask, cut or unscrew the plastic clips, pop the jaw pads out of place with a tongue depressor. Depends on what kind of helmet they're talking about here. Place your fingers inside the helmet during removal of the helmet, and the person at the side of the patient controls the head by holding the jaw with one hand and occupant with the other. And then insert padding behind that. I'm just reading because I'm not a bike rider. The few ones that I've had to do were in a traumatic situation, so I've just had to get them off. And that's just there. So look, guys, so this code right here is for chapter 29. That is not for tonight's main class. So you guys will use this for your attendance code for the one that Rob taught for me due to me being extremely sick. And so Rob's going to use, so y'all will use that for chapter 29. I am going to make sure, let me post that down in the chat too. Well, stand by. I don't know why it's 8962. So that is chapter 29 code. All right, so let me pause this. And then I will bring up tonight's lecture. So y'all hang on. Let me figure out this. Give me just a second. I'm trying to get it brought up. All right, bear with me. All right, can everybody see that on y'all screen? I just want to make sure. Somebody can just tell me yes or no. All right, cool deal. All right, so tonight we're going to do chapter 30. This will be chest injuries. This one's not super long either. That's the reason why we wanted to finish up from the other night. And y'all can do both tests as of tonight. I fixed all of JB Learning, so the tests will all open and you will have 29 and 30 opening tonight. All right, so let's get this situated. All right. Here we go. So chapter 30, chest injuries, which we know here. I'm not going to read that again. That's trauma. We've read that every single time since we've been in this module. Tonight, we're going to talk about blunt versus penetrating mechanisms, open chest wounds, and impaled objects. I want you to know the difference in how to treat, manage, and assess blunt versus penetrating, and how to recognize and treat a hemothorax. I want you to know about simple pneumothorax, what is open, simple, and tension. We will talk about those. We're going to talk about cardiac tamponade, rib fractures, flailed chest, and a Komodo cordis. It's not a dragon, I promise. I know everybody thinks about Komodo dragons, but it's not. It's not, definitely not the same. Just letting you know. All right, so let's talk about this. So obviously introduction. So injuries can involve heart, lungs, and greater vessels if it has to do with the chest. Boom, we know chest injuries includes a lot of things. It may be result from a blunt trauma, could be penetrating, or it could actually be both. We may end up be dealing with both injuries. Internal bleeding can collect in the chest cavity, compressing the lung and the hearts. Air may collect in the chest wall, preventing the lungs from expanding, which is not good. Air or blood in the cavity is not good. It's not supposed to be there. We don't want it there. We need to breathe. I'm addicted to that. Y'all remember? All right. So remember the difference between ventilation and oxygenation. Ding, ding, ding. Probably going to see this. So ventilation is the body's ability to move air in and out of the chest and lung tissues. Oxygenation is the process of delivering oxygen to the body by diffusion from the alveoli following inhalation into the lungs. I'm going to let y'all write that down because I'm sure y'all going to need it. So injuries affecting the patient's ventilation or oxygen are serious and may be life-threatening. Again, if we cut it off, you can't breathe, you're going to die. We need to fix that problem. The chest or thoracic cage does extend from the lower end of the neck to the diaphragm. Hint, I would make sure you know where the thoracic cage is. A penetrating injury to the chest may also penetrate the lungs and diaphragm and injure the liver, spleen, and or stomach. Y'all let me know when y'all are ready to move on so y'all can make sure you have ventilation and oxygenation. All right, well, I'm gonna move on. Y'all let me know if you need me to go back. All right, there's just thoracic skin, muscles, and bones have similarities to the skin, muscles, and bones in other regions of the body. So some unique features such as the striated or skeletal muscles allow for ventilation. The intercostal muscles extend between the ribs. They are not yet developed in very young children who tend to breathe from the diaphragm only, which is called belly breathing. Inverted from the spine nerves, and this allows the chest to expand on contraction and the activate portion of ventilation to occur. So where's my map? So our ribs flex through here. They flex. The children don't have that. They don't have that ability. They don't have those muscles yet. So we're special being older. I'm just kidding. So I'll show you another picture in just a second. It's gonna make it better. So the neurovascular bundle is a network of nerves, arteries, and veins lying closely along the inferior and slightly posterior of the lowest margin of each rib. There's a picture coming. And this can be the source of significant bleeding in pleural space. I'll show you what that means. The pleura covers each of the lungs and the thoracic cavity. The partial pleura is the inner chest wall lining. The viscera pleura covers the lungs. Hint, I would probably know that. A small amount of pleural fluid between the parietal and viscera pleura allows the lungs to move freely against the interior chest of the wall. I am going to copy and paste because that is important. Well, it's not gonna let me. Let's see if I can do this. It's not gonna work. So make sure you know what the partial pleura and viscera pleura is. Those are important. All right, so here, I want y'all to look at this screen real quick. So on the top side is gonna be more bones. And on the bottom side is where you're gonna have your nerve endings. You'll have some blood vessels running this way. So any type that there's, like when you hear people do a needle decompression, we're gonna go the second intercostal space above and below the second and third rib. Okay, so that's 1, 2, we're gonna go right in this place. I wanna go on top of the third rib, but I don't wanna go on the bottom because I know that there's nerve endings and I know there may be potential, some vessels there. So that being the case, be very cautious about knowing if there's any type of Pascagoula, guys. We may have some weather coming in. I'm showing decent service. I checked the up and lows, loading and upping on our service before I started because of the weather. So I'm sorry. But see, this is why you down in a different world down yonder. That's probably y'all fault. So be very cautious. That's why we were talking about you needing to know why it's on the bottom side of the ribs is what was important. All right. So the trachea divides into the left and right main stem, which supplies air to the lungs. We talked about that several times before. The thoracic cage contains the heart and great vessels. So remember, we've discussed this multiple times. The thoracic cage contains the aorta, the right and left subclavian arteries and the branches, the pulmonary arteries, and the superior inferior vena cava. If you have questions, I would go back and review that, but that is very important to know what is contained in the thoracic cage. The medial stadium is the central part of the chest containing the heart, great vessels, esophagus, and trachea. The diaphragm is the muscle that separates the thoracic cavity from the abdominal cavity. Remember, so here's your picture. The diaphragm is what separates the thoracic cavity to the abdominal cavity, okay? Make sure y'all get that. The diaphragm separates the two. All right, so the intercostal muscles between the ribs contract during inhalation. The diaphragm contracts or flattens at the same time. The interthoracic pressure inside the chest decreases, creating a negative pressure differential. So this allows air to enter the lungs because now there's a negative pressure on the inside of my lungs and I'm able to take that deep breath. The intercostal muscles and the diaphragm relax during exhalation. This allows air to be exhaled. That is adding a positive pressure, which pushes the air out, okay? Negative pressure brings it in, positive pushes it out. So here you go. So we are gonna say the diaphragm contracts and the breastbone moves upward. So the external intercostal muscles contract. This is inhalation. When we exhale, the diaphragm is at rest. The intercostal muscles contract, and there's a positive pressure, which is pushing the air out. This is a negative pressure, breathing the air in. okay? A patient whose spinal cord is injured below the C5 may lose the power to move the intercostal muscles. So C4 and 5 keeps the diaphragm alive. FYI, I've never forgotten that since I was in basic school. The diaphragm should contract. The patient still should be able to breathe because the phrenic nerve may remain in contact. The patient with a spinal injury at a C3 or above will lose the ability to breathe. C4 and 5 keeps the diaphragm alive. Any type of injuries to the C4 and 5, you're going to be breathing for the patient. They are going to be in respiratory distress or failure at that point. So tidal volume, we talked about this when we went over respiratory. So the average person has a tidal volume of approximately 500 milliliters. So the minute ventilation is calculated by multiplying the tidal volume by the number of breaths in a minute, okay? So we know what our tidal volume is. Its average is 500. And we're gonna times that about how many breaths that a patient takes in a minute. That should give us what our minute volume. Changing either of these numbers can affect the amount of air moving through the system. The average bag valve mass delivers anywhere between 1,000 to 1,500 milliliters of air. Overventilation can cause gastric distension and impair lung functions. Overventilation can also increase interthoracic pressure, introducing venous return to the heart, and thereby reducing cardiac output. So remember, we don't want to hyperventilate a patient because of these reasons. We see what overstimulation can do, or overventilation. If we hyperventilate them, we can have, bigger issues when it comes down to the end. All right, so this poor young child looks to have a seatbelt injury across their chest. So we know we're going to have either an open or closed injury, and here it appears to be a closed injury from the seatbelt. They are generally caused by a blunt trauma on closed injuries because we know the skin is not broken at that point. They often cause significant contusions in the cardiac muscles and lung tissues, which is going to be potentially a pulmonary contusion. And if the heart is damaged, it may not be able to refill with blood, or blood may not be pumped with enough force out of the heart because of the cardiac contusion. This can result into a cardiogenic shock. Lung tissue bruising can result into external loss of surface area. This leads to decreased oxygen and carbon dioxide exchange, and it can cause hypoxic and hypercarbic states. I know that's a big, those are lots of words, I promise you, but I'm just giving you the whole realm of things. Rib fractures can lacerate lung tissues and cause further vessel damage with every chest wall movement, and it can repeat to a hypovolemic shock. If you potentially suspect at all any type of a broken rib, we need to apply pressure. That way that we can keep the lungs from getting a flail chest. So here, this is a open chest injuries. And an object has penetrated the chest. We can see that either blood is coming out, the object is sticking in, or we hear something going on. Do not attempt to remove or remove this object. It may be occluding the hole in the punctured vessels. Removal can start heavy bleeding, and the damage can be caused even more during removal. So keep it in place as long as you can, stabilize it. That's the best thing that we can do. Blunt trauma to the chest may fracture the ribs, sternum, and chest wall. You probably won't see it, but in the late stages, bruising to the lungs and hearts and damage can damage the aorta. Almost 1/3 of people killed immediately in car crashes die as a result of traumatic rupture of the aorta. I had one gentleman in my career that had a ruptured aortic aneurysm, dissecting. He had a AAA. I literally watched him turn purple from the nipples up as I was trying to code him. There was nothing I could have done even if he was on the table. Some signs and symptoms of chest injuries. You have pain to the site of injury. Obviously, pain is localized at the site of injury and is aggravated by or increased with breathing, bruising to the chest wall. You may have some crepitus with palpations to the chest. Crepitus, the best thing I can tell you about crepitus, it sounds like Rice Krispies and milk. Has that snap, crackle, pop kind of, if you can imagine touching that, trying to rub your fingers and popping air pockets underneath the skin. That's really what it feels like. And it's in any type of penetrating injury to the chest or dyspnea. Remember, we talked about dyspnea about 4 billion times. You may have some hemotysis, maybe I pronounced that right. Failure or of one or both sides of the chest to expand normally with inspirations. Your rapid, weak pulse and low blood pressure. We should know what that is. Remember, we just went over that. Cyanosis around the lips or fingernails, diminished breath sounds on one side, and low oxygen saturations. Remember our tools. We have an O2 sat monitor. Let's use our tools. They help us figure out what's going on. Patients with chest injuries often have tachypnea, which is a rapid respirations, and shallow respirations because it hurts to take a deep breath. It's every time I take a deep breath, it hurts. Those are some of the things, and they're going to be guarding. They're going to be guarding that injury. They're going to turn around and be holding that area. They're going to say, it hurts to take a deep breath. Oh, God. So that's the constant thing that you're going to hear from these patients. On our scene size up, obviously, if it's a crime scene, don't go in there. If you need extra help, call for it. Call for assistance. Call for AOS. Call for immediate assistance from the police department. If needed, call for electrical companies. You may have the fire department. You may just be an ambulance service. Chest injuries are common in motor vehicle crashes, falls, any type of industrial accidents, and assaults. Determine the number of patients and consider spinal mobilization. That is important. We need to figure those things out on the front end so we're not trying to play catch up. Mechanism of injury. Chest injuries are common in motor vehicle crashes, falls. I just said that. It's kind of the same thing. And determine the number of patients. Same thing. Primary assessment. All right, so on our primary assessment, what are we going to do? We're going to build a general impression. Do I see any life-threatening injuries? Or do I notice any type of heavy bleeding? Do I need to fix any type of ABCs immediately? Should anything be addressed immediately, even before airway concerns? What catches my eye? Do I see something that has to be fixed right now? Okay, and perform a rapid physical exam. Let's go head to toe as fast as we can, see if there's anything going on. All right, so on our airway and breathing, we're going to do a decap BTLS. We're going to touch them. We're going to touch their chest. We're going to make sure that they have good inspiration and expirations. Ensure that the patient has a clear and patent airway. If they're talking to us, bingo, but let's still do our assessment. Consider a cervical spine stabilization if we suspect any type of blunt trauma. Note whether you see JVD, that is jugular vein distension. If you see signs of pressure, which is a tamponade on the heart, that tells you why there is a JVD there. Determine whether breathing is present or adequate, or present and adequate. Look for equal expansion of the chest wall. Check for paradoxal motion, means that things are moving normally on both sides. Abnormal is associated with multiple fractures. So if there's something that is not moving, if you do not have paradoxal movement, suspect any type of rib fractures. Apply occlusive dressing to any type of penetrating injuries to the chest. apply oxygen, which we know we're going to give everybody oxygen. It's the best thing in the world, and provide positive pressure ventilation with at least 100% and breathing if breathing is inadequate. Be alert for decreasing oxygen saturations. Remember, again, let's use our tools. Our tools are there to help us. Be alert for signs of impeding tension pneumothorax. Circulation. Assess the pulse and determine whether it is present and it is adequate. If the pulse is too fast or it is too slow, if the skin is pale, cool, or clammy, consider the patient to be in shock. That's signs of shock right there. That's the best thing we can do is consider that. And I'm going to, at this point in time, we're going to assess any type of life-threatening injuries. If there's any type of external bleeding that needs to be addressed, that needs to be handled ASAP. Transports, how are we going to take them now? Are we going to wait? What are we going to do? We need to transport these patients based on our decision from what we've done. What is their appearance of their skin? What's their level of consciousness? Do we feel that let's say this. So if the patient says, I feel I'm going to die, let's take that serious and let's transport them. That's impeding doom. Some people say that most of the time when patients state that, those are true facts, and let's just hold their word for it. I just say we should transport them. When in doubt, transport the patient rapidly to the hospital. Where's the button? All right, so here is a deadly dozen chest injuries. I'm gonna let y'all read that real quick. I'm gonna get me something to drink while y'all are reading that. All right, let's keep on moving. So history taken. Well, I want to get enough information that I can. I want to investigate their chief complaint as in detailed as I can. We're going to figure out trying to investigate the MOI, identify associated signs and symptoms and pertinent negatives. What stands out to me that I need to know? Questions should focus on the MOI, speed of the vehicle. That is important. Use of any type of safety equipment, type of weapon used, number of penetrating wounds. On our sample history, complete a basic evaluation if the time allows. If it's a load and go, and this is a rapid situation and we treat life-threatening injuries, that's all you get to. You don't get no information to pass on. You leave it like it is and you continue to struggle all the way to the hospital. On our secondary assessments, this is when we come back and we're able to do a detailed assessment of the particular areas. If we come down to a certain body region and it needs to have something else addressed that is not a life-threatening issue, this is the time that we do it. Assessment of an underlying symptoms, anterior and posterior aspects of the chest wall, changing the patient's ability to maintain adequate respiration. These are all when we're starting to do our physical examinations. We're going to do our more detailed. We're going to be able to dive off into it a little bit more detailed and trying to figure out what else I can do to fix things as we move forward. The significant trauma, like affecting multiple systems, you need to start with a rapid physical exam. Use the DCAP BTLS, determine if you have any to determine the nature and extent of the thoracic injury. I want to know what caused it. I need to know what's going on. Let's try to fix it. And I'm gonna tell you, DCAP, BTLS, those acronyms are very, very helpful to you in moving forward, obviously in your career, because we go over it so much. You learn it now, you will continue to use it all throughout the EMS career. Vital signs, this should be done initially and then every 5 minutes or less if it is a low and go rapid patient. If it is a non-critical patient, they can be set to every 10 to 15 minutes. A rapid pulse or respiratory rate may indicate that the chest wall is injuries causing decreased and available in oxygen. So the patient may be suffering from hypoxia, or that blood loss is resulting in decreased red blood cells, considered hypoxemia. So again, they're having difficulties breathing. So we need to understand why that their rapid pulse or respiratory rate is being caused. Pulse and respiratory rates may decrease in later stages of chest injuries. Also think about shock. Their chest injury is starting to have issues, and now that they're compensating from what's happened to them. Their fight or flight mode from the epinephrine dump has started to wear off. Repeat your primary assessment, reassess the chief complaint, make sure that nothing has changed. Say, sir, I just want to make sure Mr. Fred are you still complaining of center chest wall pain that is from the seatbelt, or can you point to me where your chest is still hurting, or is it radiating anywhere else? Make sure you confirm what's going on. Again, we go back over our airway, breathing, pulse, perfusion, and bleeding. Those are critical life-saving things that have to be addressed before we go any further, because if those things start having any issues, those 5 topics, we're going to lose our patient. We're going to be going into cardiac arrest, and it's going to be a lot more work than just a simple chest injury. All right, so anytime that we do something, we need to reassess and observe trends. If we notice we see a change in their vital signs, let's check it again. If we notice that every 10 minutes we've had a decrease or an increase, that's a trend. If you're having to provide appropriate spinal cost stabilization for the patients from a blunt trauma with a suspected trauma injuries, that's an intervention. If we had to maintain an open airway, if that had to continuously hold it open and I put a aftermarket device in there, you control significant or visible bleeding, place a vented chest wall, a chest seal, or occlusive dressing over an injury. Those are all interventions. So during our reassessment, we have to go back and check these out to make sure that they're still working, that they're in place, they haven't moved, or they're having dislodged, or they're still holding or controlling the bleeding. Provide aggressive treatment for shock and transport rapidly. Remember, if we recognize that somebody's in shock, like we can put them in the Trendelenburg position. That's where we elevate their feet, leaving their body at a 45-degree lower angle. Communicate and document all relevant information to the staff of the receiving hospital. This can't be any more clear. Right here is that bold sentence. Communicate all relevant information to the staff of the receiving hospital. All right, so let's talk about pneumothorax. That's important, and I need something to drink, so hang on one second. All right, so a pneumothorax is defined as an accumulation of air in the pleural space. Air somehow has entered through a hole in the chest wall or surface of the lung. The patient attempts to breathe, cause the lung on the side to collapse. Blood passing through the collapsed portion of the lung is not oxygenated. Breath sounds on the affected side of the chest wall indicate different conditions. If the lung is collapsed past 30 to 40%, you may hear diminished breath sounds. So when you're auscultating both sides of the chest, you will hear one side and you may not hear the other side at all. Absent breath sounds may indicate a tension pneumothorax, and a sucking sound on inhalation at the sound of rushing air or exhalation indicate that the chest wall has been penetrated. So it's not like that, it's not going to be that obvious. You will hear a sucking sound, but it's not going to be majorly drastic that you're going to have to try to listen for it. You may hear this weird noise and you're like, what is that? The first time I heard a sucking chest wound, I was like, that is not what they told me it was going to be. And what's the deal? So it's not as obvious as they try to make it out to be. All right, so here they're trying to show you what a pneumothorax is. You see that the partial pleural air is in the space of the partial space. So what we've talked about before, and then the collapsed lung is happening here because now this is all filling with a pneumothorax. So this air right here is not supposed to be there. It needs to go. So at the same time as that is where your ALS provider, your paramedic and or partner, or you may be by yourself, your ALS only can do a needle decompression and help remove this air. No. An open chest wound is often called a pneumothorax or sucking chest wound. After clearing and maintaining the patient's airway and then providing oxygen, these wounds must be rapidly sealed with an occlusive dressing. A flutter valve is the one-way valve that allows air to leave the chest cavity, but not return. Sorry. Follow local protocols and the manufacturer's guidelines on what you are able to use. An occlusion dressing where the flutter valve may be taped to the patient's chest on 3 sides of the dressing. Allow air to leak from the 4th side. After applying the dressing, carefully monitor the patient for signs of a tension pneumothorax. If it develops, open the occlusive dressing on one side. So what it's doing is basically it's allowing it to burp. Here's your picture right here. Oh, go next. So air is coming in and out. No good, no good. So that is a pneumothorax. We got to fix that. So we put on the outside here, we can put a 3-sided occlusive dressing. Most of the time, if I'm going to do it, I'm going to do tape on this side, tape on the top, and tape on the bottom. The bottom, tape on the right side, left side, and the top. The bottom side is the one that I'm always going to leave open. Just in case it needs to, the burp, it needs to be open on one side. And it's 99% of the time it needs to be the bottom side. All right, so what is a simple pneumothorax? So a simple pneumothorax does not result in major changes in the patient's cardiac physiology. It is commonly the result of a blunt trauma that results in fractured ribs. Some signs and symptoms include pleuritic chest pain, dyspnea, tachypnea, accessory muscle use, decreased oxygen saturation, and a cracking sensation felt on palpation of the skin, which is, we talked about subcutaneous emphysema. Late findings can be decreased breath sounds on the injured side, as well as lethargia and cyanosis. No. Pre-hospital high flow O2 is very important, and monitor oximeter readings and breath sounds. It's basically kind of what we can do there. So a tension pneumothorax results from ongoing air accumulation in the pleural space. The air is gradually increasing the pressure. Air gradually increases the pressure in the chest. It causes complete collapse of the unaffected lung. No. Medial stadium is pushed to the opposite side of the pleural cavity. Common signs and symptoms include chest pain, tachycardia, marked respiratory distress, low or rapidly dropping oxygen saturations. A patient may present with a JVD, cyanosis, or tracheal deviation, but these signs are not always present. Pre-hospital treatment. So what can we do in the field for a pneumothorax? We're going to support ventilations with high flow O2, request ALS support for transport and immediate rapidly transport. Needle decompression may be performed by ALS personnel or ED staff only. Well, it really depends on your local protocols, but on a national standard, that is really done by ALS or higher. Let's see here. This is a tension pneumothorax. So you have wound to the lung and a wound to the chest wall. These are both equal wound sites. There is air filled in here. The lung is collapsed. You see our bulging intercostal muscles is right in here. So you're gonna have, that is a tension pneumothorax. See how everything is, so this is supposed to be midline. Everything right here is supposed to be straight up and down. This has caused the shift of everything to the patient's left side, because remember, this is the right lung, this is going to be the left lung, and it has caused everything to move. So you see the heart is being compressed, the aorta, vena cava, the lung, all that is compressed because it is pushing it over because air is filling up more and more in here. This needs to be let loose. You may be able to burp this. What happens here, this piece of tape needs to be removed and some pressure needs to come off so that it is not a tension pneumo no more, where everything's being compressed. All right, so a hemothorax. Hemothorax is a condition in which blood collects in the pleural space from bleeding around the rib cage or from the long or great vessels. So here you can see this is a hemothorax where blood has filled all of this pleural space, all right? So a hemopneumothorax, blood is heavier than air, so it goes to the bottom, and then the air is filled up here. So now we have both. So the air is coming into the top, and somehow or another we also have blood that's going to the bottom. So yes, you can have both, a hemopneumothorax. They are rare, but it is possible to happen. All right, suspect a hemothorax if the patient has signs and symptoms of shock without any obvious external bleeding or decreased breath sounds on the affected side. What can we do in the hospital or in the field? You can transport rapidly, provide rapid transport to the nearest facility capable of performing surgery. The presence of air and blood in the pleural space is known as a hemopneumothorax. All right, so a cardiac tamponade. So a cardiac tamponade or a precardial tamponade occurs when the precardial sac fills with blood or fluid. The heart then cannot pump adequate amounts of blood. So you see right here, this is the normal heart with the sac. It's going to have fluid around the heart no matter what. And then you have right around here that the cardiac or precardial tamponade has created with, now there's so much fluid around here that the heart is shrunken and it's not able to, it does not have enough elasticity or room in there to allow it to pump normally. Signs and symptoms refer to the Beck's triad. It includes a distended or engorged JVD on the neck. So what we can do in the field, honestly, guys, is support ventilations and rapidly transport the patient so they can have interventions inside the facility. JVD is a very serious condition that needs to make sure that we pay attention and that is recognized early. Rib fractures, they are painful. Rib fractures can cause a hemo and pneumothorax or both. So if you suspect it, try to recognize that early, assess that, look for those and try to fix any type of injury that you can. Patients with one or more cracked ribs will report localized tenderness and pain when breathing. The best thing that we can do to them in the field is give them supplemental oxygen. So here is a flail chest. So look here. So we have more than one rib that's broken. And this is, you see where it's broken right here from the costro separation. So this is where it's going to be very painful. These are all joined on this side. So our injury, our blunt trauma happened right here. The easiest thing that we can do, well, let's back that up. So right in here, you're going to notice paradoxal movement because this is not moving as one unit. You'll see these go in on inhalation and them come out on exhalation. It's really weird. So the best thing that let's see, hang on. I may have, I'll tell you that in a second. So pre-hospital treatment, maintain the airway, provide respiratory support, give supplemental oxygen, perform ongoing assessment for complications. Best thing you can do there is put a hand, like a gloved hand on there, apply a little bit of pressure. And it's not like it holds it in place, but at the same time, it doesn't hurt them in near bad. What we used to do back in the day is we used to use sandbags. Yes, I know, sandbags, but like old IV bags had some sand filled up in them, taped up and all that. And that was enough pressure, enough weight to apply that would help the patients breathe way better on any type of multiple rib fractures, or you saw paradoxal movement. So treatments may include positive pressure ventilations, restrict chest wall movement. So here we talked about this. So splinting of the flailed segment with bulky dressings. It is no longer recommended, but it does provide some. Y'all stand by, I'm gonna have to beat a dog. I'm sorry. My little dog has decided she loves the garbage can now. Never does it in her life until this week. So they say that it's not fully recommended anymore, but it does provide them a lot of support, just a lot of discomfort, pain, like the pain just goes away. You don't have those issues. I'll still do it to this day, to be honest. If it comes something that I'm gonna have to fix, I'm gonna end up doing those and treating them that way. I'm gonna apply a little bit of some pressure there and add that stability to them. Flailed chest may indicate serious internal damage and possible spine injuries. Don't 100% know that it won't be a spinal injury, but most time if you have enough force to break the ribs, it can have other serious conditions. Yes, most time those are resulted there unless it's a traumatic event. Pulmonary contusion, obviously that is telling me just by the sound that I'm going to have some type of bruising or damage to the respiratory system. The pulmonary alveoli become filled with blood and the fluid accumulates in the injured area, leaving the patient hypoxic, which we know what hypoxic is. So tells me I'm going to be a little short of breath. Best thing we can do here is we're going to provide supplemental oxygen, positive pressure. Those are the best things that we can do to fix it at that moment. Some sternal fractures. These are super, super painful. It does require a significant amount of force to the chest. It may involve the lungs, great vessels, and the heart. Any type of clavicle. I've had one clavicle injury my entire life, and a dude was running with a battery on his shoulders, and that's how he broke his clavicle. He said it was super, super painful. I know 12 morphine didn't touch that. So be alert to possible signs of a pneumothorax. Suspect upper rib fractures in the medial clavicle areas if that's the case. Here is a picture of a traumatic asphyxiation to where they suffocated. It is sudden severe compression of the chest, which produces a rapid increase in pressure within the chest wall. This is characterized by the distended neck veins, cyanosis in the face and neck, and a hemorrhage in the sclera of the eye. If you were to look in here, his eyes would be bloodshot. A lot of times you will, like, let's say somebody's digging a hole and they were in the hole and the hole collapsed on them. That can be a traumatic asphyxiation because it squeezes against their chest real tight and they're unable to get that elasticity for them to breathe. A crushing injury here, maybe something pinned them and they were unable to breathe there also. This Suggests an underlying injury to the heart, possible pulmonary contusion. Does provide ventilatory support with supplemental oxygen. Monitors vital signs, which we know we're always going to be checking vital signs pre and post on anything. Blunt myocardial injury. So blunt myocardial injury is injury to the heart itself. It is making it unable to maintain adequate blood pressure. Often the pulse is irregular. It is dangerous. It does have dangerous cardiac rhythms, but such as ventricular tachycardia and ventricular fibrillation are uncommon there. Suspect myocardial contusion in all cases of severe blunt injuries. So anytime that you suspect any type of chest injuries, automatically assume that they're going to have some type of cardiac contusions and that the heart is going to be bruised and it's going to cause irregular pulse rates, pain, and basically mimic any type of chest pains. Monitor the patient's pulse carefully. Note any changes in blood pressure, because remember, we're building trends so we can pass that on to the facility. We're going to provide high flow O2 right in here. Transport immediately. Commotio cordis. So blunt chest injury caused by a sudden direct blow to the chest that occurs only during critical portion of a person's heartbeat, resulting in immediate cardiac arrest. The resulting ventricular fibrillation is often responsive to defibrillation and early initiation of CPR. So if it is recognized ASAP and they start it instantly, you will have more results than waiting for your first responders to arrive. More commonly associated with sports injuries, but should not be suspected in all cases in which a person is unconscious and unresponsive. Laceration of the greater vessels. This is probably going to be something that's going to be fatal. The cardiopulmonary resuscitations. We're going to have to start doing our pre-hospital. We're going to start doing CPR. We're going to have to ventilate them. We're going to transport that immediately. Remain alert for signs and symptoms of shock. Closely monitor the changes in the baseline vital signs, including tachycardia and hypotension. Guys and gals, this is very simple. Tonight's class is over. This is chapter 30's class test. Since it is so early, I will go into JB Learning and open up the test starting at 8 o'clock tonight. So you will not have to wait the extra 2 hours. So the extra 2 hours is on me. So your class code for tonight is 716?67. That is chapter 30's test. Attendance code, sorry. And again, if y'all will give me about 20 minutes, I will go in there and have the test to open up at 8 o'clock tonight. I wish y'all the best. Have a good day. Have a good evening. And I will see y'all Thursday night. See y'all.